Today we're going to talk about product selection and dosing for red cell and platelet transfusions. Packed red blood cells are used to replace absent red cells to support oxygen carrying capacity. They are used to increase intracranial vascular volume to support cardiac output, and they are used to increase intravascular osmotic load in patients with severe capillary leak. Typically available in units which were approximately 300 milliliters in total volume. NICU patients are frequently transfused multiple times from single units assigned to them, and those patients will be discussed in other recordings. Packed red blood cells are typed and cross-matched between the recipient and the donor unit. This is where the blood is taken from the patient and tested against an antibody panel to determine what their blood type is. And then the cross-match occurs when plasma from the recipient is tested against red cells from the unit to make sure the unit is compatible. This type and cross-match period is a time to slow things down. Errors occur in this when they're rushed, and clerical error and other type and cross-match error are associated for the vast majority, over 80% of all lethal transfusion reactions. So remember the old saying, if you have 10 seconds to do something, use 9 seconds to think and 1 second to do. This is one of those times to slow down and think through things. Cross-match red blood cells are used particularly in the environment of a trauma situation or a mass transfusion situation. These are typically blood group O negative red cells and are used only in patients with extremis. Another indication for these is some patients who have pan-reactive red blood cells, pan-reactive antibodies to red blood cells, and these are oftentimes transfused with these uncross-matched red blood cells or with best available cross-match. So dosing and rate. The dose of red cells is based on the patient's weight in kilograms and on clinical indication. The typical dose is 10 mLs per kilo infused over 3 hours. This gives you a rate of infusion that is unlikely to cause volume overload in an otherwise healthy person. The dose can be modified based on the recipient's hemoglobin and cardiac status. If the patient already has congestive heart failure symptoms, then slower transfusion or smaller transfusions repeated over time are the usual approach. And for chronic anemia, a good golden rule is the rule of 3s and 5s. A hemoglobin below 5 indicates the anemia has been present for a long time and the cardiac output has been supported by increasing plasma volume. To infuse an entire 10 mLs per kilo dose would put the patient into more fulminant heart failure. So there we use smaller repetitive doses, 5 mLs per kilo or 3 mLs per kilo, and then these transfusions are repeated over a course of 24 to 48 hours until the hemoglobin gets into the desired range or the patient's congestive heart failure symptoms abate and a more normal dose can be given. Platelets. In cities where there's a large volunteer blood supply and single donor pheresis platelets are easy to obtain, these are the preferred product for all recipients. And in our hospitals, they are the standard unit given. In other environments, in locations where single donor pheresis platelets aren't available or are restricted in their availability, random donor platelets, which are the platelets recovered from making packed red blood cells, can be used. So indications for a single donor pheresis platelets include immunocompromised hosts, where there is a lower risk of bloodborne infection from having fewer donors, a history of anti-HLA or anti-red blood cell antibody production means you're more likely to make antibodies to future blood transfusions. And so if you can do one donor with a large quantity of platelets, you have simply fewer donor exposures. Anticipated need for an allo stem cell transplant is using these products is associated with a lower HLA antibody risk. And dosing for random donors is usually dosed at 0.1 units per kilo, rounded up to the nearest whole number of units, and then the max dose is 6 to 8 units. A single donor pheresis unit is dosed at 5 to 10 mLs per kilo with a maximum dose of 1 unit, and these units can range from 3 to 600 mLs and can be volume reduced or split depending on the clinical indication. Platelets are infused by a gravity or syringe pump. They are not put through a rotary pump because they will activate the platelets in the rotary pump or destroy them. Peak platelet count can be measured 30 minutes after an infusion, and we should expect approximately a 30,000 platelet increase. Indication for platelets: bleeding, platelet count of 10,000 where bleeding is likely to occur, and a platelet count target may be raised depending on other factors. Factors leading to a higher platelet target: bleeding at previously noted bleeding at higher targets. A patient who has severe nosebleeds or severe mouth bleeding at a platelet count of 40,000 would be transfused at 40 or 50,000, recognizing their previous bleeding issues. History of cranial radiation or surgery. These are patients who are typically treated with a platelet count of higher than 50,000 because of the fragility of the small vessels in their brain and the concern about hemorrhage. Mucositis, particularly post-bone marrow transplant, where they can have really gross severe mucositis with bleeding, DIC and coagulopathy. A patient may have chronic platelet consumption because of these issues and require a higher platelet number in order to restrain bleeding problems. And then platelet counts which near 20,000. In the case of a leukemic or other patient with thrombocytopenia, 20,000 is typically used rather than letting the patient go lower because of historical factors. Some of these historical factors related to how platelets were counted before Coulter counters were available, and then how platelets were counted using chamber counts, which are highly prone to human error. And the difference between a 10,000 platelet count and a 20,000 platelet count was literally one platelet on a microscope slide. So thank you for your attention, and if you have any questions, please drop me an email. Bye-bye.